Hi, very good evening. So, how are you guys doing? So, I hope you took adequate rest after giving the exam yesterday's INS set. I hope you guys are all back to form and are enthusiastic as usual. In fact, with double doses of enthusiasm after yesterday's exam experience. So, today's live session, quick revision class, will focus on few select topics from oral path and medicine. I hope you guys are all ready, and please confirm the audio and video streaming. We'll proceed accordingly. So today I'm going to introduce to all of you my another new friend, the flyboy. In fact, the picture which you are seeing now, I've taken this in 2014. So using, at that time I had my first DSLR, and it was one of the earliest pictures which I have captured in speed mode, that is point and shoot mode. And this is what I could achieve way back in 2014. So with time, we'll learn many things, especially the technicalities when you're dealing with certain arts. So photography is definitely an art, right? So this is what I succeeded in capturing today. So in today, this morning, early morning, so in my garden, I found the flyboy again. I named him as flyboy. So yesterday's character which you have seen, so I named him as good boy, the oriental garden lizard. So I named him as good boy, and he is flyboy. He is nothing but dragonfly. As you can see, well articulated surfaces, and also you can see two pairs of wings and very neatly arranged. This picture has really taken me by surprise because I didn't expect this kind of architectural configuration in flyboy or in dragonfly when I initially took pictures some years ago. So today when I was trying to capture uh, some garden insects, so this is what I could succeed in capturing. And you can see in the central portion, you can see a bulkier body with a tiny head, and you have legs. They seem to be like long, thin legs. It appears like an alien. And also there are two pairs of wings, and you can see how symmetrically they are arranged. Various structures to allow it to fly very fast and very efficiently. So with this, let's start our quick revision class, oral path and medicine. Yes, wings are really very beautiful. So our 13th live session. So we'll start with our first question. Identify the syndrome with features of convex facial profile, a prominent nose, retrusive chin, downward sloping of palpebral fissures, colobomas of lower eyelid, mandibular and midfacial hypoplasia. Options include Down syndrome, mandibular facial dysostosis, mandibular facial synostosis, Marfan syndrome. In exams, if questions were in this direction or in this particular format, it would be very convenient for all of us to answer, right? So it's like giving you the answer and asking you to identify the question. I think we should incorporate these kind of questions, especially in Viva, which most of the students find it very challenging or very inconvenient, or for that matter, very irritating. So, which one do you think is a more appropriate answer? Identify the syndrome with features of convex facial profile, a prominent nose, retrusive chin, downward sloping of palpebral fissures, colobomas of lower eyelid, mandibular and midfacial hypoplasia. Good. So majority of you have chosen the right option. So Treacher-Collins syndrome or mandibulofacial dysostosis, as you all rightly mentioned, primarily affects structures developing from the first branchial arch. Consider this very, very important, right? So I'll just present you some illustrations and simultaneously we'll review this literature. Treacher-Collins syndrome primarily affects structures developing from the first branchial arch, but it also involves the second branchial arch to a minor degree. And individuals have a convex facial profile, as you can see in the right part of this illustration. And there is a prominent nose with retrusive chin. It is generally a bilateral anomaly with the characteristics including downward sloping of palpebral fissures, as evident in the left illustration. And along with that, There is coloboma of lower eyelid. Colobomas are conditions where the normal tissue in and around eyes are absent, right? So colobomas of lower eyelid and mandibular midface hypoplasia as evident in the left illustration with deformed pinnas as evident in the right part of this illustration. So, as you all rightly mentioned, mandibular facial dysostosis or Treacher-Collins syndrome. Option B is right answer. Okay, Wonder movie is based on this. I didn't knew that. Thank you. Thank you for the inputs. So, is it an English movie? I would definitely love to watch it. Now, let's move on to our next question. So, always when you go through syndromes, whenever you get an opportunity, always go through the literature while you are simultaneously viewing the illustration or the clinical images. This way of learning obviously will be more effective, will be more fun comparatively, compared to just going through theory, compared to just going through text, isn't it? Now, let's move on to our next question. So, Treacher-Collins syndrome, you are never ever going to forget the clinical features because you have clearly seen the clinical images, right? Now, second question. So, this is something which is out of box based on predilections. Let's see how many of you are going to answer it right. It's a non-odontogenic cyst with distinct female predilection of 4:1. So, which one do you think suits this particular description or features? Nasolabial cyst, nasopalatine cyst, traumatic bone cyst, dermoid cyst. So, which one do you think is a more appropriate answer? So, non-odontogenic cyst with distinct female predilection of 4:1 among the following. So, females have a beautiful nose and beautiful lips, right? So, just remember that way, or in any way which is convenient for you, so that you would remember these facts in a concrete manner. So, female predilection, nasolabial cyst. So, dermoid cyst, there is no gender predilection. You can make a note of additional points as well. So, in case of dermoid cyst, there is no gender predilection. In case of traumatic bone cyst, usually seen in younger people, especially teenagers who are most commonly affected, and an equal gender distribution has been noted. Nasopalatine canal cyst, the majority of the cases occur between 4th and 6th decades, which we discussed in one of the previous live sessions, oral radiology. And men are more affected than women comparatively, with a predilection range of as high as 3:1. Nasopalatine, males have greater chances of having this nasopalatine, that says 3:1 predilection compared to females. And nasolabial cyst. So, nasolabial cyst is a rare lesion with a peak incidence between 4th and 5th decades, usually noted during these years. And there is a distinct female predilection of nearly 4:1. Okay? So, nasolabial cyst, option A, as most of you have rightly chosen, is the right answer. So you can remember it that way. Females have beautiful nose and lips, so nasolabial cyst. So don't try to gather mnemonics or these kind of short forms of phrases for all the cysts, because again, you might land up in confusion. Just one cyst, I'm sure you'll remember at least till the date of exam. So in this particular case, you can see a bilateral nasolabial cyst. You can see some bluish tinge, right, beneath the mucosa. So it's a case of bilateral nasolabial cyst. So option A is right answer. Now let's move on to the next question. I'm sure you all have clarity regarding these terms: silidinitis, silolithiasis, silectasis, and silosis, which we'll try to discuss in this particular live session. And also try answering this question. A generic term for a group of metabolic disorders that may cause salivary gland enlargement is. So which one do you think is more appropriate answer, or which of the following terms suits this description? Silidinitis, silolithiasis, silectasis, silosis. Yes, females have beautiful nose and lips, and Ankita says males have beautiful heart. Thank you, Ankita. Yeah, agreed. So which one do you think is more appropriate answer? In the meantime, let's review some terminology. So sylectasis, dilatation of a duct. So sylectasis is an uncommon condition of salivary glands which involves dilatation of a salivary duct. Ductal dilatation is a chronic process and occurs most often secondary to obstruction by siloliths, that is stones within ducts, but may also be caused by strictures or stenosis. Additional reports suggest that masseter hypertrophy may also play an etiological role in case of sylectasis. And most often, this condition affects the parotid gland and largely spares submandibular gland. Some additional points or take-home message. Silithiasis, just which we have seen in this context, stones. So benign condition with formation of stones within the ducts of major salivary glands of head and neck. This can lead to superimposed bacterial infection like silidinitis. Okay, so the ducts which are the glands which are usually involved, the ducts and glands which are usually involved are parotid glands, submandibular glands, and sublingual glands. And silolithiasis is most common cause of salivary gland swelling with reported incidence of 1:10,000 to 1:30,000. And silidinitis, itis means infection, inflammation. So silidinitis is the infection of salivary glands, usually caused by the virus or bacteria. The parotid and submandibular glands are most commonly affected. In silidinitis, we will have classical clinical features like pain, tenderness, redness, gradual localized swelling of affected area. And as most of you have rightly mentioned, yes, option D. Most of you or some of you? I think you have chosen all the options A, B, C, D. Well done, which means one of you must be definitely right. Isn't that a good sign? Isn't that a collective victory? Okay, yes. Silosis, a generic term for a group of metabolic disorders that may cause salivary gland enlargement, is silarinosis or silosis. So these conditions usually affect the parotid glands bilaterally, typically in the absence of inflammatory processes or symptoms. Chronic alcoholism, dietary deficiency, obesity, diabetes mellitus, hypertension, and hyperlipidemia have been linked to this clinical salivary gland abnormality. And alcohol cirrhosis or chronic alcoholism and even asymptomatic enlargement of parotid glands occurs in around 30 to 80% of the patients. Right? So this is some additional information based on literature review from Regzi, Oral Path 4th edition, 192 page. If you're interested, you can review that further. Yes, option D is a right answer. Okay? Yeah. Now, let's move on to our next question. Abhishek says your lectures are great. Glad to hear that, Abhishek. Appreciate your love and affection. So, fourth question. All of the following causes are attributed to xerostomia except. So, which one do you think among the given options doesn't cause or lead to xerostomia? Silosis, sarcoidosis, anticholinestrases, cytotoxic therapy. So identify the right option. In the meantime, let's review some information. So as per the information given in Neville, 3rd edition, page number 464, dry mouth or hyposalivation or xerostomia. It's a common subjective complaint, but objective evidence of hyposalivation is less common because it could be even psychological. So it could be rather a bit perceived than real. The main causes are iatrogenic and non-iatrogenic. So this is something which is very, very important, knowing the causes of xerostomia, which we discussed in one of the study club discussions as well. So various iatrogenic causes include anticholinergic drugs. Remember, listen carefully. I'm not talking about anticholinestrases. I'm talking about anticholinergic drugs or sympathomimetic drugs like tricyclic depressants, phenothiazines, antihistamines, etc. And other iatrogenic causes like irradiation of salivary glands during radiotherapy, and also cytotoxic drugs, graft versus host disease, or anything that destroys the salivary glands. And non-iatrogenic causes like dehydration, Sjogren syndrome, sarcoidosis, HIV disease, salivary gland aplasia, developmental, etc. Silosis, caliculi, or removal of a single major salivary gland rarely can cause xerostomia. So sequelae of hyposalivation obviously include caries, candidiasis, and ascending silidinitis, which is quite obvious and understandable. And anticholinestrases, as some of you have mentioned, anticholinergic drugs, we're not talking about anticholinergic drugs. We're talking about anticholinesterases, which are cholinergic in nature. So anticholinesterases, so just a brush up from pharmacology, they cause hypersalivation. Anticholinesterases are agents which inhibit cholinesterase enzyme and protect acetylcholine from getting hydrolyzed. And this results in cholinergic effects in vivo and potentiate acetylcholine both in vivo and in vitro. And various cholinergic actions include increase in secretions, right? Secretion from all parasympathetically innervated glands is increased, like sweating, salivation, lacrimation, gastric secretion, etc. And additional points, the effect on pancreatic intestinal glands is not marked. Secretion of milk and bile is not affected, right? So anticholinesterase, if it is anticholinergic drugs, then there is no right answer. But anticholinesterases cause hypersalivation because they are cholinergic in nature. That is, increase the secretions in general. Okay, so option C is the right answer. Okay, if you're wrong, don't worry. It's time to update the information in your mind and then progress accordingly. Now let's move on to the next question. It's a challenging one. Let's see how many of you are going to answer it right. So, discrete purple red papules or bony prominences such as knees, knuckles, elbows are noticed in which of the following conditions? Viscott-Albrecht syndrome, Chidiac-Higashi syndrome, dermatomyositis, desmoplastic fibroma. So which one do you think is more appropriate answer? So discrete purple red papules over bony prominences such as knees, knuckles, and elbows are noticed in which of the following condition? Yeah, I think most of you are getting it right. Well done. So try answering this question. In the meantime, let's review some literature. You can see the clinical images. So dermatomyositis, it's one of the major systemic inflammatory diseases of connective tissue manifested as inflammatory myopathy with characteristic cutaneous findings. Main dermatological findings in dermatomyositis include heliotrope rash and Gottron's papules. So these are the two things which I want you to highlight because you can consider them very, very important. What is this heliotrope rash and what are these Gottron's papules? In fact, the question is based or devised based on the location, anatomical location of these papules. So heliotrope rash is a distinctive violaceous or violet in color, slightly edematous periorbital swelling as evident in illustration E. It is found most often on upper eyelids. Gottron's papules, Gottron apostrophe S. Gottron's papules are discrete purple red papules over bony prominences, as you can see, over knuckles and various elbows, various other bony prominences such as knees, knuckles, and elbows. So, in the process of this discussion, you heard of a term called heliotrope rash. So, what is this heliotrope rash? We'll get back to that. But before that, discrete purple red papules, that is Gottron's papules or bony prominences such as knees, knuckles, and elbows are noticed in dermatomyositis, as most of you have chosen. Okay, well done, and just keep this enthusiasm going. By the way, this is from Regacy, okay, 4th edition, page 406. So you're seeing these images, keep them in mind, and you will never ever be forgetting about this dermatomyositis, at least till the date of exam. Okay, now what is this? Why do you think I've placed it? By the way, this is not my picture, I haven't captured it. Heliotrope rash. We have this term heliotrope rash because we have a plant by the name heliotrope. So purple eyelids, which is one of the clinical manifestations of dermatomyositis. So we've named it as heliotrope because purple eyelids, which are described as heliotrope, because they resemble heliotrope flower, which is Heliotropium peruvianum, and which has small purple petals, as you can see, hence we're calling it as heliotrope rash. Violaceous. If you observe the description, heliotrope rash is distinctive, violaceous, slightly edematous periorbital swelling, right? Named after Heliotropium peruvianum, sun-exposed areas. Okay, helio, sun, right? So, well answered, everyone. And if we move on to the case-based question, the final aspect of this presentation, A parent brought her 10 days baby to dentist with a chief complaint of ball-like growth in maxillary gingiva. So they're giving you the anatomical position. On examination, it is pedunculated lesion in incisor region arising from malleolar crest, measuring 2 into 2 centimeters. So you have the dimensions. So what might be the provisional diagnosis? I'm not presenting you any clinical picture. I'll try to present you in the next session. But based on the given information, so which one do you think is more appropriate answer describing this particular condition or situation, clinical situation? Granular cell tumor, Neumann's tumor, granular myoblastoma, rhabdomyoma. So you can review literature, note down these hints, and then try to find out the answer and relevant information. We'll discuss that in the first part of our next or upcoming quick revision class. Okay? Yeah. It's up to you if you want to answer. Yeah. Kavita, you need any further clarification regarding any options, you can use our doubt clarification form and get back through mail for further assistance. Okay? I really appreciated enthusiasm. It seems most of you are choosing option B, but I wanted to recheck your answers. Okay? Okay, guys. So I really appreciate your enthusiasm and just keep this consistency and momentum going. Yesterday's exam is definitely is a mind opener for all of you because it might have given you a real exam like experience because it's a real exam like scenario. So using those experiences, so where did you find it challenging to answer questions in such a computer-based test? And what are your weaknesses? So keep asking yourself these questions and try to work out on your weakness. Did you find it difficult to answer questions in time? Did you find it confusing? Or do you feel like you need further revisions to have more clarity on certain topics? So you can get all answers to these questions based on your performance yesterday, irrespective of how much you score or which rank you get. So that's something which I want you all to introspect and ask yourself these questions and work accordingly so that you can progress and even improve further and give your best for the upcoming NEET MDS exam. Okay? So a happy weekend, all of you. And most importantly, don't worry about the consequence or result. Today I've received a specific mail where the student was asking me, like, sir, if I start studying from now, will I get a government seat? See, my answer, I'm sure most of you might be, or all of you might be having this question, like, will I crack into government seat? My answer or my suggestion is very simple. There is no point in thinking about the result or output even before giving the exam. You might have an idea about your preparation phase, but why do you want to speculate and make calculations now when you have quality time with you to prepare and give your best? So practice well, make sure that you're making most use of the available time. Focus on giving your best and leave the rest. So if you can do that, if you can really do that, you'll definitely have results in your favor without any doubt, right? Who is going to give us any guarantee? If someone asks you, like, can I get or can I crack entrance into a government college, who's going to give us a guarantee? None. No one. If someone is giving you a guarantee, they're just fooling you. Who is going to give us a guarantee? It's us. It's our preparation which ultimately matters. And who knows about our preparation? Ourselves. So don't get fooled by someone who says that I assure you government seat. No, there is nothing of that sort. First of all, thinking about result or output is a stupidest thing to do. Rather, smartest thing is to focus on what you're doing now. Instead of trying to enhance your knowledge, instead of rather than enjoying the process, if you're overwhelmed or if you're just thinking about the result, output, rank, marks and all, then what's the point in preparing? Do you think you're preparing for sake of marks or rank? No, not at all. You're preparing so that you're laying a stronger foundation at undergraduate level so that this helps you at your postgraduate entrance or postgraduate level and rest of your clinical practice and in your academics. So this is all trying to master the game, trying to master at the basic level. Marks and ranks will be a consequence, will be a natural consequence. And you want best marks and best ranks, that will be a natural, successful consequence once you focus on the task at hand. It's a very simple equation, and let's not make it complicated by investing our negative thoughts and emotions, right? In fact, I was going through one of the quotes of Dalai Lama, who clearly states the same. Humans have the capacity to work out their emotions in such a way that they can, or they have the power to either entertain positive or negative thoughts. So in which direction are you investing your intelligence? In cultivating negative thoughts or in cultivating positive thoughts? So that's what human intelligence is for. And the choice is completely ours. You want to be happy, you will be happy. You decided to stay unhappy, you decided to stay worried. None is going to help us. None. Literally none. Not even our parents, not even our loved ones. Because ultimately we are in charge of ourselves. That's a brutal fact. That's a simple fact. Appears to be brutal, but that's a fact. We need to accept the same and take charge of our thought processes and just enjoy what we're doing, which ultimately matters. Just enjoy what you're doing, right? And let me conclude with this, and we'll give a break to our quick revision classes, and we'll try to focus on paper discussion videos of INSET from Monday. So we'll have a break, and from Monday we'll have continuous paper discussion videos regarding INSET. And for the next 1 week to 10 days, we'll give a break to our quick revision classes, because so far we tried to cover or touch all clinical subjects. Next, in the second phase, we'll move on to basic subjects, and then again, we'll move on to clinical subjects or case-based patients, depending upon the requirement. Okay? So consider this as a temporary stop to quick revision classes, and I really appreciate all your active participation, and just keep this consistency and enthusiasm going. You have nothing to worry about, because you are in charge of your own thoughts. Not me, not someone else, not your parents, not your loved ones. That's a simple fact. Appears brutal, it's okay. It's all about perceptions again. So it's a simple fact that you are in charge of your thought processes. You want to be happy, you want to be successful. The choice is yours, 100%. Okay, so let me conclude with this. Have a great weekend and see you all very soon. We'll be coming up with more updates in our Telegram or Google Updates group regarding paper discussion videos. And also, have any keywords or key points or any questions related to yesterday's exam, you can get back through mail at howtobedentist@gmail.com. And for that matter, if you need any further assistance, any further clarification regarding, it can be academics or general, you're always welcome. Contact us through mail at proudtobedentist@gmail.com. Also, you can check our website, ptpacademy.com. So, wish you all the best. Love you all. Good night. Yeah, thank you. Thank you, guys. And appreciate all your love and affection. Thank you. And all the best. Take care. Yeah, Devi, dot clarification form, it's available in general section. All free resources which we are providing to everyone are available in general section of our e-classes. You can just log into our website through guest login, the general section where you can find several free resources, including dot clarification form. Okay, Sudarshan, sir, will I pass? Of course you will. Agalia, glad to hear that you enjoyed the session, Agalia. You're welcome, Shreya. Yes, Shweta, you're most welcome. Thank you, Kavita, for your love and affection. Awakin, we'll provide you recorded videos, okay? Recorded videos of paper discussion. Yes, Isha. Gargi, you're welcome. Okay, Jani. Jani wants us to continue quick revision class. Sure, we'll consider. We'll consider a request. You're welcome, Amreen. Renuka, I think we discussed about the next plan of action. Yeah. Okay. Okay, guys. So I think I covered all the comments. Okay, if in case I missed, please get back through mail. I'll definitely answer and address or go through your queries or concerns, right? Yeah. Good night. Okay, Amreen, that's glad to hear. Welcome to our live session. You can find plenty of our live sessions in our YouTube channel. Also, you can just drop a mail for any further